Okay, so the next 2 sessions with Kim and I, we broke it down into non-progressive medical conditions and progressive medical conditions. So what I'm going to do in this session is describe what is a non-progressive condition, and then I'm going to provide you some examples of, again, possibly common diagnoses or disabilities that you may come across in your journey, and I will explain the presentation, which is what it looks like to you, how it appears on the person. I'm also going to explain the etiology, which is the cause of the condition. How did they get that? A mechanism of injury is another thing we might say. So that will explain how they got that disability. And then any complications or concerns that we sometimes can see, kind of regardless of which context or situation they're in, and kind of regardless of how you might interact with them or when you would meet someone with a disability. So almost regardless of the context. I'm going to move this one more time, and I know it makes just a horrible noise, but okay. Okay, so what is a non-progressive disability? Something that is non-progressive will not worsen over time. The symptoms do not progressively get worse. They may come and go. They may come and go intermittently, but they don't worsen. It may or may not also be permanent. Okay, so some of these conditions or diagnoses that I will talk about, they may be related to an acute injury, and then over time, it may go away. Some of these diagnoses or conditions are permanent, though. So we'll talk about that it can be either. Sometimes disabilities or the symptoms related to the disability can be managed with medication or other types of treatments, surgical options, therapies, things like that. And what I want you to think about oftentimes too is contextually, in the context, environmentally, what can exacerbate the symptoms, and what the client would need in that situation, what type of special attention or immediate attention in some cases. Okay, so the first subcategory and the non-progressive are repetitive or overuse conditions, which personally is what I've seen a ton of with relating to equipment use, processing, farming, work-related injuries. And so that's why I'm bringing this today, because what farmers do is heavy labor, lots of work, and all day, right? I feel like the individuals that I have come in contact with, they don't take a whole lot of breaks. They wake up early and they start work, and they don't stop until the work is done. And so sometimes our bodies react negatively to that. Our bodies are only meant to do so much, and especially as our bodies age, the tolerance for that type of activity can decrease. So what happens with repetitive or overuse conditions is anytime you move your body, your brain tells your body that you want it to move. A muscle contracts and extends and contracts and extends, so the muscle pulls on the tendons. So fun fact that I think is really important is the difference between a ligament and a tendon. A ligament will always be connected bone to bone, and tendons connect muscle to bone. So when you hear tendinopathy or some of these tendon inflammations, and you say, well, I thought it was the bicep that was irritated, or I thought it was the extensor muscles that were irritated. That's sort of true, but those all muscles attach to a tendon, which pulls the bone. And so each time that muscle shortens and extends and shortens and extends, it's pulling that tendon taut. So sometimes you can have breakdown in the tissue of that tendon, and tendons also don't have a lot of blood circulation, so the healing can be really slow. The first one I want to talk about is lateral and medial epicondylitis, also known as tennis elbow or golfer's elbow. So tennis elbow is lateral epicondylitis, and golfer's elbow is medial epicondylitis on the inside of your elbow. And it's very common. So what happens is I would dare to say, just again off of my own numbers, that at least 15% of you in this room have felt this pain in your elbow, especially if you're doing a lot of repetitive wrist motion, a lot of turning. And so what happens, itis means an inflammation. And by the time that you actually seek assistance, medical help with a lot of these conditions, it's so far advanced and you've had it for months. And so that's part of the problem then, is because the inflammation is pretty bad in that tissue. It takes a while to heal it. Okay, so that's just a little bit of quick anatomy lesson with these type of overuse conditions. Trigger finger is also related to the tendon, and it's a lot of sustained grip or repetitive grip. So when I think back to some of the injuries that I have treated with a trigger finger, levers, if you work or have a farmer who has some sort of hose that they have to constantly be squeezing this lever or squeeze and maintain that squeeze, that really puts a lot of stress on that tendon and can inflame it over time, and then it starts to catch. So if you're not familiar with trigger finger, that's what that is. It catches because it's swollen. Cubital and carpal tunnel are nerve-related injuries. Again, from the contract and release of the muscle belly, it compresses our nerve. And there's a nerve that connects to every single part of your body, because our brain is connected to those nerves, and our brain has to tell our body what to do. So those nerves can be compressed, and that's when a patient or anyone would have numbness, tingling, and other issues like that. De Quervain's is yet again another tendon overuse, only it's right here at the thumb. So and this is a fun fact. Yes, I'm an educator, I teach, and thank you, Ned, for reining me in, because I tell a lot of stories when I teach. My mind gets distracted. And Kim too, you kind of go off on your tangents, personal stories. And so what I want to share with you is going back to the trigger finger. I had a patient who worked at, it must have been like a bird or poultry factory, and they had this hose that came down from the ceiling, and they had to wash like all day, but the lever didn't stay like it does on a gas pump, like it should, right? That makes great sense. But this one didn't. They had to hold it. Well, this person ended up getting trigger fingers and even some de Quervain's and lots of issues. So what I did is I took some what we call thermoplastic, and it's a plastic that we soften in hot water, and then we mold it around. So what I did is I essentially made this cuff that fit over the glove of this client. Now, I know some of you out here are engineers or professionals with assistive technology, but this is an example of like very, very low or no tech. There was nothing special about it. It was a piece of plastic that I molded, but so that it would hold the hand in place down on the lever, and that individual didn't have to keep squeezing and sustain that grip. So I like to think that I made a difference long term for that person, but I never saw them again, so that's why I'm telling myself that. They did great.
Does trigger finger just stay shut? Is that what you mean by catch?
Yeah, so trigger, kind of, it can. So if anyone has ever had trigger finger or knows someone who has had trigger finger, that tendon gets really swollen and inflamed. And when you go to make it fist, it goes down into the palm, but when you go to extend the hand, it gets stuck underneath what we call like a sheath. It's kind of like too tall of a truck going underneath a bridge that's not tall enough, right? It gets stuck on the one side and can't go back. So some people will force it open, which just makes it worse. So when it catches, a lot of times it gets stuck, but people can overpower that. It's painful, and it's not good for that tendon. And most oftentimes, unfortunately, as I had mentioned, with these overuse conditions, someone has been repetitively doing this. It could be work related. I can't stop working. I have to keep working, so I'm just going to fight through the pain. And then 9 months later, they're like, I can't even dress myself now. I can't brush my teeth or wipe myself now. So now I need to go get help. And at that point, so much damage has been done to the tissue. So, yeah.
So if it's not okay to force it back,
Yeah.
what's the best way? I see this in my future as a tire person, so you don't know.
Oh, yes.
There we go.
Yep. Repetitive gripping or flexing of even just one finger can do it. So are you asking what you do on the front side of that, or if your finger does get caught?
You can't force it back.
Oof.
What do you do? You just walk around?
Yeah. Well, what you could do is pull it open and then just not fully flex that finger again. And so that's sometimes what I'll tell people, because you automatically do. It's almost like if you dislocate a joint, your automatic reaction is to fix it, even though you're in excruciating pain, because it's freakier to have, a bent finger from trigger finger. But that would be the only way of preventing it from locking or clicking or catching again, is by not flexing your finger, which, think about everything we do in life from the moment you wake up to the moment you go to bed, and how many times you flex your fingers. Everything we do. And so you would have to see a doctor. You would have to see a physician, and then it's just a quick little surgery. But
So
yeah, sorry, what?
done to that before? Like if you notice that it's starting to get bad?
Yep. So you'll start with a little bit of pain in the palm or at the bottom of your finger, and you might even feel a little bump. So if you have that could be the beginning of that inflammation. And what you need to do is limit how many times you are gripping or repeating. So one thing I wanted to talk about with all of these conditions is that taking breaks is really helpful or important. So again, if you're on if whoever you are coming into contact with either has one of these diagnoses, or you're suspecting like, oof, they're getting pain here. It could be pain, just anything. Pain in my neck from constantly having my head down like this. Pain in my neck from constantly up and down in my head, or rotation of the neck. And so those are things where taking a break is one of the best suggestions that I have. But in this particular case with trigger finger, it's limiting how many times you grip or flex that finger. Bend, sorry.
And so like you said, with creating the
Yeah.
low
Yes.
thermoplastic solution,
Uh-huh.
you might also look at, can you put a clamp on that instead
Yep.
of having to hold it the whole time, or those
Exactly.
things, which might be more preventative.
Yeah, how can you minimize how many times that gripping has to occur? So those of you who are the AT engineers, the brain behind, I might have an idea, which I've also made an error and tried to do it myself. I'm not an engineer. My brother got those brains. And anyways, I spent several. I had another patient who had rheumatoid arthritis. So that's a condition where he couldn't flex his fingers, and he didn't work on a farm, but he had a large property that he would carry like 5-gallon buckets often, and he carried these buckets. But when he got this diagnosis, as it progressed, which I'm not sure if Kim is talking about this particular type of arthritis, but that's a progressive type of disease to the joints, and as it progressed, he couldn't grip anymore. So anyways, I tried to make him a cuff that again, out of that plastic, and I molded it around his wrist, and I made a hook. And I thought, well, if he just wears it like a bracelet, and then there's a hook into his palm, he can just lift it. Well, I spent a really long time doing it, but it worked great when the bucket was empty. When you put something in it, it just wasn't staying, and I was so disappointed. And then I Googled it, and it was on Amazon for like $13. It's a weightlifter's cuff. And so again, sometimes, it's just a matter of looking it up or speaking with an assistive technology professional. So anyways, I'm also working on that partnership and learning. That's not my profession. So did I answer everyone's questions on that? Okay. So those are those examples. Again, this is kind of repetitive here at this point, but what does that look like? Again, what is the presentation of an overuse repetitive injury? Painful movements. It's going to hurt. It's going to hurt. It's almost point tender. You can point to it with a single finger, and that's exactly where it hurts. And that's where that tendon attaches to the bone, and it's getting inflamed from that repetition. Over time, it will create weakness. So now you have pain. Anybody like to go through pain? No? Nobody? Right. So what happens if something's painful, stop doing it, right? That's what our brains tell us to do. Do it a different way or just completely stop doing it. When we can completely stop using a certain muscle group, that muscle group gets weak. So now you either go through pain or you start having weakness in that movement that may be required for pulling, pushing, lifting, reaching, doing a lot of things that we do every day, but with that movement. Yes.
Personal example of how it can happen.
Oh, yeah.
Age to anybody, but I had Deborah's tendonitis in
Oh.
my right thumb. I knew exactly what it was because of my occupational therapist. I made myself a split.
Oh.
24 hours. It was so much better until the exacerbation when it recurred in the spring after I sprayed and hit my shoulders.
Yes.
It was the static holding and oh gosh, and this one didn't work after that. And so I babied it and stopped using it, and it felt better. And then I started to get a pain in the elbow.
Oh, no.
I was overusing a different part. And it worked its way up until I said, okay, time to stop treating yourself and go to the But it took till it was like all the way up to my neck because I kept overusing a different body part.
Yep. Our brains are smart, and we do learn to compensate, right? Okay, can't use that because that hurts. I'm going to try it a different way or a different hand. And that happens a lot too. You notice that you're getting clicking or catching or pain in that finger from repetitive gripping. I'll try doing it with my non-dominant hand then. And now you have issues in that hand, right? So that can happen too. I mean, we're smart enough to think, let me find a different way to do this, but that unfortunately can occur. So sensory disturbances, so that's kind of like numbness, tingling, zingers, buzzing. Some people even explain if there's a sensory issue. Remember, sensory is something sensory related in the environment, and our body picks up on it, whether it be through our eyes, through our ears, through our mouth, through our hands, and it talks to our brain and we process what that was. And then the output is our body's movement, the motor response. And so anything sensory related, and this specifically is related to the tactile sensation, so the way that it feels on our hands, and that can feel like numbness, vibrating, tingling, and those issues, which is like a kinked hose. And this is how I explain it too sometimes, that if you start feeling, first you'll feel tingling, like when you've been sitting on your foot too long, or standing too long, or shoes are on too tight, or something like that, right? You'll feel tingling first, and then if you don't do anything about it, it will go numb. And my 3-4-year-old loves that feeling of the prickers on the bottom of her feet, but I cannot stand it. Yes, it's awful. So so I don't like the way that feels, so I'm going to change the way I'm sitting if that's occurring. If you think of a garden hose, if you bend the hose in half, then maybe a little bit of water is maybe still dripping or trickling out. And if you don't correct it and it sits like that all summer long, and then you go to put your hose away in the winter and you're like, oof, and you release it, that bend is still going to be in the hose. Right, and I'm talking the older basic hoses, not the fancy zero hoses that shrink up to nothing. And so that's kind of what can happen to our nerves, is that they can be compressed for so long that there's a complete numbness after a certain point, and it's very difficult to get that back. Nerves are very particular and sensitive, fragile. Okay, so again, what can we do about this is taking more breaks. And other modifications or adaptations to their workspace, equipment, and tools. And it would require that comprehensive, what do they need to do for this work? And a lot of times someone doesn't know what's causing that numbness. Sometimes they don't know what's causing the pain, and you have to ask several questions to funnel down and figure that out. What is a concern if sensory is involved, though, when sensory is disrupted? Think about everything we do is sensory, but specifically on our hands. The sensation that we get from our bodies tells us if there's anything dangerous in our environment, specifically temperature related. And there are a lot of tools and equipment that put off lots of heat. There are sharp things that we work with, especially agriculturally. And so needing to detect those items in our environment, we need to be able to feel. And if that is impaired, then potentially that person's at risk for injury. Another injury. Okay, so moving on to amputations. Another fairly common thing that you'll see, that we see in our community. This may or may not have occurred related to like a farming injury. Sometimes it is something congenital. They are born with it. But what an amputation is basically a body part has been removed. Sometimes that happens, again, injury related. It could have been cut off by a press. Fingers, arm, foot, something was caught into an engine. I have seen a lot of amputation injuries related to anything with a mechanism that turns. So thinking lawnmowers and snow blowers and saws, anything that turns with a motor gobbles up fingers, let me tell you. So amputations are unfortunately pretty common when it comes to big equipment and tools and things that turn with a motor. And so when you're talking about an amputation or see something about an amputation, they are labeled, or their type is labeled according to the level of whichever limb and where on the limb that there has been the missing body part. Okay. Something to consider. Oh, I'm sorry, this is still like what this might look like. A person may have phantom pain or sensations, and phantom pain and sensations are two different things, but they are two very real things, even though you may think phantom means like illusion of pain. No, they are actually experiencing pain in the limb that is missing. Excuse me. I didn't bring my water up with you. So their body really is experiencing pain in that missing limb, or absent limb. And same with sensations. They may feel like that's still there, that finger, that toe, that arm, that leg, but it's gone. Yeah.
Pain medication, dissolve, things of that sort.
You know what's interesting? It's not over-the-counter pain medications. It's more nervous system pain medication. So like a oral nerve block. And so doctors, if it persists, but there are actually non-medicated treatment options to help decrease some of the phantom sensations and pain, because it's a lot of our brain is saying the connection is still there from our brain to, for example, my hand, but my hand's gone. So why do I feel like my hand is still there? Why do I feel like my thumb aches or something like that? It's because of the connection from our brain is still there. So there are treatments to help retrain our brains into using our body without that hand there. There are those medications prescribed by physicians, but it's actually more related to the nerve process for that. So great question. Yeah. So real pain experienced and real sensations experienced by the absent body part. Hypersensitivity just means overly sensitive. Again, speaking tactilely, very sensitive touch. Sometimes it's just the wind blowing or getting dressed that may send like this chill through someone, because it is so sensitive, and it could even produce some pain, some very adverse response.
Stephanie,
Yes?
what's the right word to use for where the body part was cut off?
So this is an interesting question as well. A lot of times, individuals, what I emphasize is do not call it the bad arm. It's not a good or a bad arm, and so we're not going to call it a bad arm. A lot of times it's referred to as a stump. If they have a prosthetic, it's referred to as a terminal device, because it operates like a tool. So residual limb is another one depending on how much, like, again, I've seen several finger amputations, but it can be at any level. It could be, my father-in-law actually has one right now from a saw. I don't know why he still has a saw. He has cut his hand so much from a saw. Anyways, and so he had just the tip of his thumb was amputated because it got down into the bone and infected and things like that. So they just removed it. So what he has is a stump of his thumb left, versus like if you were missing an entire hand, that would be more like a residual limb from the wrist or forearm up.
And is that where the hypersensitivity happens?
Yes.
The residual limb?
Yes, at the tip of that. What happens, whether it's either an acute injury like a car accident, machinery will like I say, that'll take off body parts. When you go to the hospital and the physician fixes it, they will remove the damaged tissue, bones, and all of that, and they take those nerves that are still coming from the brain and our spinal cord, and they kind of wrap them up and tuck them into where they would cover with skin then. So those nerve endings are really close to the skin surface, and that's why that's just so hypersensitive. There are treatments for that as well, non-medicated related, that we do as therapists, where we will desensitize that particular body part or area. So, yeah, very good questions. There's also balance disturbances with amputation, and I don't just mean with the lower limbs. You can have an imbalance in movement when there's been an amputation on the upper limb as well, because we're used to doing things, if it's an acute related injury, we're used to doing things fluidly, without even thinking, unconsciously. We get up, we get out of bed a certain way. And this is the other thing. If you guys could all just take 5 seconds and think, how do I actually get out of bed? Do you sit up and turn? Do you roll? What side are you waking up on? All of these things that we just don't even think about. Our bodies just do it every day. And same thing getting back into bed. And so when you lose a body part unexpectedly, you haven't trained for this. It's not a marathon. You're not expecting to have to do that movement without that body part, and it can be a little bit wobbly, when you go to start getting yourself dressed again after, you're home from the hospital and rehabilitation. And so even if an amputation is on the upper limb, it can still present some balance disturbances, and especially in the lower limb. So that's something to be aware of as well. Possible prosthetics. Also called terminal devices, yes, or use of a wheelchair or crutch. This is not necessary or required. This kind of also goes back to patient or client preference. What is it that they want? There are lots of different types of prosthetics out there, and so you may see them, and sometimes you don't even notice that it's a prosthetic. That's what's really cool and really advanced now. Some of them are just for aesthetics. They just want it to look like a hand or like a foot again. And so that's what they get. They don't get a functioning tool at that point. It doesn't do anything. There's no technology to it. It's just there for aesthetic purposes. And there are some very advanced prosthetics. There's a cable oriented device, and then there's even neuromuscular devices where the technology is massive and advanced now, where the brain's telling this prosthetic what to do. It's just really fascinating. So at any point in the timeline after an amputation, an individual can be experiencing these listed. How am I doing on time, Ned? Am I okay? 10 minutes? 20? 15?
We're going to go 10 more or 15 more minutes.
Okay.
And take a break wherever you're at.
Okay. All right. Thank you. So some considerations for amputations is that these individuals may need to be trained in one-handed technique. So again, if it's their dominant hand, their right hand, and it's missing, it's gone now, it's absent from their body, they may choose not to get a prosthetic, and instead, I'm going to learn how to do it with my left hand. Okay, let's do it. And it takes time, it takes practice, it takes problem solving and patience. And so there are one-handed strategies, there's non-dominant strategies as well, and that's specifically related to the upper limb. For lower limbs, again, they may have chosen to not select a prosthetic to help with that ambulation, that walking around, and instead they might be using a wheelchair to get from place to place. And or crutches or a cane or a scooter. There are lots of different devices out there for them. And so also keeping in mind sensitivity to temperatures and pressures in their environment, because it may trigger those unpleasant responses. And I kind of mentioned this at the beginning of talking about amputations, that sometimes it's just the breeze blowing or getting dressed, and it makes them sick. It's this pain response. Can be a pain response, and everyone is different. And so being aware of what's in their environment and the temperature of the environment, as well as I put an image of some sharp objects here because they may not always sense that, and that puts them at risk for an injury.
And I think
Yes.
because farmers typically work outside so
Yeah.
much,
Oh, yeah.
that temperature safety can be a real issue.
Absolutely. I think I pretty much talk about sensation almost in every one of these subcategories because it can often be affected. And yes, working outside, winter and summer, and regulating that temperature, detecting that temperature changes, because again, just like sitting on your foot, you know when to move. When it's really cold, you know when to get a jacket. But if you have a sensory disruption, it's not telling your brain that because it's not detecting that it's cold and needs a jacket or gloves. And so prosthetics, again, could be selected by the patient or client to help manipulate tools. There's some really, really advanced prosthetics out there. And other environmental modifications to consider for someone to be able to optimize or maximize their safety, which we kind of already talked about with just being aware of the environment and having access to temperature adjustments or regulations and being efficient. So a lot of times, I think that you'll probably talk about this too over observations and just energy conservation ideas, is just getting them closer to what they're working on. What I could have you, some of you brought a laptop, and what you could do if you wanted just a snippet of this is if you carry your laptop around this room 10 laps straight out in front of you with arms straight, it's not going to feel good. It's going to hurt all over your body that you didn't even think about that it would. If you could even hold it up for 10 laps, right? But if you bring it close to your body or even fold it up here across your body and walk 10 laps, you could do 20 with no issues. So I like to think about the environment, bringing those clients closer to the activity that they're working on or bringing that activity closer to them. And I've seen some really cool equipment from Ned if somebody does have difficulty getting up and down or up from down in a field, getting low to the ground and wheels. Anything wheeled really helps facilitate or maximize efficiency in those activities where they have to get low to the ground. So getting them close to the activity or the activity close to them, and sometimes that means height-wise as well. Okay, so yes? Okay, two more subcategories to cover here, spinal cord injury and then brain injury. So we'll hit spinal cord injury first. What is a spinal cord injury? It is an injury to the spinal cord. Okay, so think about central nervous system includes our brain and our spinal cord. And it's connected. So I think maybe it's not on here, but there's an image of the brain, and then our spinal cord is connected from that, and it travels all the way down our back. It's well protected by a bony prominence, our spine. And so that helps protect the interior spinal cord. But that spinal cord is full of nerves, and those nerves connect to our body to, again, receive sensory information from our environment and output and send out motor responses to what we want to do. So injury to that actual spinal cord can present issues with not only feeling things, but doing things then, if that makes sense. Spinal cord injuries can be traumatic or non-traumatic. A traumatic spinal cord injury oftentimes is related to a fall or a blow to the neck or the back. Sometimes from a car accident, it can just be that spinal cord overstretching the spinal cord and the nerves then. And so those are traumatic in nature, trauma to that spinal cord. Non-traumatic spinal cord injury are things like tumors, infections, other congenital differences when someone is born with an injury, spina bifida, for example. And spinal cord injuries can be complete or incomplete. That basically means complete is permanent, forever and ever, never changing. Incomplete can vary and potentially improve. Complete kind of means essentially there has been a complete cut to the spinal cord and separation of the spinal cord. And an incomplete means it could just be torn or stretched, which is promising for those individuals who have had the diagnosis of an incomplete spinal cord injury because they're hopeful that those symptoms and those responses might improve. So here's a little visual for you. There is the spinal cord itself, and it's color-coded. If you have access to this slide, you can see that the colors on our spine are connected to specific parts of our body, and that is, again, for sensory input and motor output, for functioning, daily functioning. The type is related to, or the description is related to the level of the injury. So we have cervical spine, thoracic spine, and on it goes down, and so it would be related to where it is the injury is on the spinal cord, and that's what the name is linked to it. So that's what that looks like. What are some considerations for individuals with spinal cord injury? They potentially could have no sensation whatsoever, and wherever it is on the spinal cord relates to where it is on the body, and it may affect their ability to feel their legs, their feet, their bottom. So one thing we are concerned about, I'm sorry, I'm jumping to the bottom of this slide, is skin breakdown. And that's probably because it's my first concern always, is educating clients to monitor their skin for any changes, because if someone sits for too long and can't feel the foot going numb, then if they can't feel it, then they're not going to change. And if you don't move, especially on a bony prominence, like the ankles, the heels, the sit bones, the elbows, the back of the head, the shoulders, those are all spots that are prone to and at a higher risk for skin breakdown because they're so bony and the skin is a lot closer to the surface, and that can break down. So knowing a skin monitoring schedule and knowing when to move their body around and not sitting too long, that is a consideration for those individuals. There are other life-threatening changes in blood pressure. It can either drop or skyrocket. And both of those need a quick response. Specifically one where they would have an increase in their blood pressure means that there's some sort of strange stimulus, and it could be something like a full bladder. Sometimes individuals with a spinal cord injury can't feel when their bladder is full, like the rest of us can. And so they need to be on a schedule as well to void that urine, because a full bladder could trigger a life-threatening issue with their blood pressure. And so they would need to, sit upright, empty their bladder, kind of check and make sure there's nothing poking them or too tight around them, and calling 911 are the things that you need to address right away with these individuals, or they would as well. So, any questions so far? Okay, I only need like 5 more minutes. Are we good? Can I just
let's
finish up? Okay. And so a couple other considerations. Wait, did I? Shoot. Now, I can't go back, but I'm pretty sure I hit all those considerations. Okay, thank you. And so, okay, and I already hit this one too, bowel and bladder and skin checks. So they may need schedule accommodations. They may need periods of time where they can step away from their work, and they need to have an environment that is hygienic and clean to be able to sanitize their hands, take care of what they need to as far as bowel and bladder and their skin, and then they can get back to work. But that does take time, and it's very important that that is built into their routine. And so...
And can't be put off. Because
Nope.
so many times you want to just finish, like you want to finish your set of slides.
Yeah.
But-
Yes. If anyone needs to go do a skin check or bowel bladder, go ahead. But you're right.
But for a farmer, I'll just finish
Oh, yeah.
this row, or I'll just finish this row.
Exactly. And I kind of, what I thought about with the place to be able to take care of those things too, if you're out in the middle of a field, where are they going to empty their bladder? Which is a process, which I'm not getting into today, but it is a process. And how are they going to clean their hands and clean that area? And so not only the time, which a lot of times, yes, it cannot be pushed. So sometimes we'll give them timers, and they have to just follow the time. The cell phone, what great technology. You can build those alarms right into that. So yes, thank you. It can be difficult also talking about temperature, environment, being out in a field, winter, summer in Michigan, it varies. Only half of you are from Michigan, right? So some of you might be from southern states or really warm states or colder states. And so whatever your environment is like, individuals need to be able to regulate that body temperature to prevent any other responses or issues. Regulating pain and fatigue as well is really important with these individuals so that they can, again, optimize their routine, maximize their safety and efficiency with work and life. Some other musculoskeletal concerns or considerations, they may have limited movement or spastic movement, which means just very jerky and tight movements instead of the rest of us, can have fluid movements, right? But if there's a spinal cord injury, that can affect that motor output, which may present with some tight, spastic muscle responses.
Talk about spasms before you go on.
Yes. So spasms are similar to spastic responses. And with our muscles, again, we condition them to what we need them to do every day without even thinking. They just respond to our level of activity. Spasms are similar in that they are uncontrollable, unplanned, unpredictable times where our muscles contract and release so quickly that we can't overpower it. There are some strategies to help with spasms. It's actually heat will help relax muscles. It's kind of like whenever you have a headache or you feel like your body's just so tight, what do? You sit down, you rest, you get some heat, you might take some medicine. So there are ways to manage spasms, and so that can be a consideration of what might occur. And it takes time. So individuals with spinal cord injuries, they really need certain times blocked out in their day to take care of themselves so that they can continue participating in all the activities they want.
Are they usually in the legs? When someone has a spinal cord injury, like that they leg will kick or something? What is that?
Yep. So it would be in the affected level. So again, my apologies. I cannot go back a slide. Oh, no. I could press P, but P did nothing. So I'm sorry.
During the break, we'll work on backing up.
Okay. Yeah, so wherever the injury is on the spinal cord, anything lower than that is going to be affected by motor or sensory. Anything above that will not be affected. So if the legs are a lot of times the legs are affected or the lower extremities are affected just because their input-output is lower on the spinal cord. It's way down here in the back. So if at any level of the spinal cord that is injured, everything below that, which could include the legs then, are affected. So if they are affected, that's probably maybe why you're thinking that, or what your experience is, and you've seen spasms in the lower limbs. It's because most of the time they are affected because our brain is not fully connected, motor or sensory, to control that. So it's involuntary movement. Yeah.
Larger muscles. They tend to be larger muscles, so the spasms are more noticeable. It's your big quadriceps. They're overfiring versus, your bicep. It's much smaller. Right.
Yeah, back. Any other questions? Okay. Okay, just really quick, some other environmental considerations. I tried looking for that all-terrain. I have pictures of it somewhere from a couple years ago, and I couldn't find it. So this looks very similar to it, but this has anyone seen a wheelchair like this, an all-terrain wheelchair? So cool. The Tracks, yeah, that's one of the brand, I think.
See it tomorrow.
Oh, wonderful. Great. Okay. So, all-terrain, wonderful. Because if someone is using a wheelchair, rough terrain is not conducive. It's not easy. It's not tolerated very well by that equipment. And so an environmental consideration for someone with a spinal cord injury who uses a wheelchair and or a cane or crutches, they would need to have a certain terrain, ramps. You can kind of build like a wooden sidewalk plank kind of thing if they needed to get out into a field and they did not have an all-terrain wheelchair. I did also find out that in some government-funded parks and beaches, you can, if you use a wheelchair, you can rent these. They only have a few, and they're not at every beach or park, but it's something that people don't know about. And so they're available for those who don't have an all-terrain but want to participate in that. They want to go through a hike through the woods. They want to go to the beach. And so those are available. Great question. I'm sorry, I don't know about internationally. Oh, they are. Wonderful. Thank you.
Also see something with, I don't know what they're called, balloon tires or whatever,
Yep.
white sand.
Yep.
They may not do so good on some other times.
Mhm.
They don't have as good kind of lugs. But
Yep. Yes, exactly. Levers and switches for instead of door knobs, instead of knob faucets at sinks and things like that. So someone who may not have full motor control of bending and extending their fingers to be able to grip those type of things, a lever might just be easier, more accessible for them. So sometimes levers and or switches are easier to operate for some individuals versus a knob. Okay.
So what's your name again? Fancy. I was for a year. They only do AgrAbility or something, and I could join that call whenever they had it.
Already started recording the sound out.
Oh.
The next segment of the session. So I met a few OTs on my way out of here. Are there other occupational therapists here? If you could just please just, okay, yes, and then yes, and any occupational therapy assistants in the crowd? Okay, great, cool, awesome. Yes, love it. Thank you. Okay. Any physical therapists since we're going there? No? Okay. See, OTs representing. All right. So the last section I want to talk to you about is brain injury. And so not to be confused with head injury. A brain injury is actually when the brain is injured. And so it doesn't always mean just a stroke or other diseases that can affect or attack the brain. It is sometimes, a concussion can joggle the brain around and do damage to the brain. So essentially, a brain injury is insult to that brain tissue or the structures, which on the image you see here. So the colored portion of the brain are the hemispheres of the brain, and then there's a subcortical group of structures that are also connected to the brain, and then you see this small tube-looking structure. That's the spinal cord, so it comes straight down from the brain. So insult to the brain and its structures can be, again, traumatic or non-traumatic. A blow to the head. So if you hit your head against something, something hits your head. A quick deceleration from a car accident, slamming on the brakes. Again, that can joggle the brain and do some damage to the tissue within our brain. Falls are really common as well. And so, unfortunately, a lot of these injuries can occur, if you can imagine, on a farm or in a facility where there's processing and there's equipment, and you just stand up and hit your head, or something falls on you and you hit your head, or you're getting off of a tractor, getting on a tractor and you fall, or a ladder and you fall. So a lot of these can occur in that type of a setting. There are also non-traumatic brain injuries that can occur, and that would be from things like infections in the brain or the system. Substance abuse can also present with brain injury, chemical exposures, other tumors, and congenital issues.
What is congenital?
Congenital is something that someone is born with. So genetics is one thing. Congenital occurs during that developmental prenatal phase. Okay, thank you. Nope. I'm so sorry. Now it's not going at all. One moment, please. I say to the room full of technology interest people that technology is my friend and my enemy. So sometimes.
It's mine too.
Because they're both grayed out now, so I don't know.
I know. It has to do with the recording.
Okay. Yeah. Okay, so what does brain injury look like on a person? It can be potentially a complex combination or series of physical changes, mental, cognitive, emotional symptoms that can present and can impact, again, daily routine type things. And memory, attention, vision, speech, and language are also associated with brain injury, and that might feel like a crossover from the cognitive type of stuff, and that's because it is. This is crossing several of those borders between physical and cognitive, and maybe even some mental health conditions that we talked about in the very first section when we talked about disability. Remember the umbrella term. So that's what that may look like. As I mentioned before, with the sensitivity to light and sound is pretty common. And again, it might be more initially, but sometimes these individuals need to wear sunglasses inside and outside. And so environmentally, what kind of considerations do we need to think about, or concerns that these individuals may have? And that's just one thing that can enable them to continue participating in those activities. So if it's sunglasses, okay. They may also need to wear headphones to dull or mute out some of the external input and sound. These individuals may also experience headaches, migraines, pain in the head and in the brain. And so they may need to take breaks that can be medicated and managed that way as well. Some other concerns that you could run into with individuals with a brain injury, sometimes they don't have the inhibition or the safety awareness judgment that that an intact brain, an uninjured brain may have. And that's because a lot of those decision making and the judgment calls happen or occur from the front part of our brain. And when the brain hits the skull quickly, and that damage occurs at the front part of the brain, oftentimes from a car accident or from a fall, is when the brain kind of sloshes around in the skull, and it hits the bony skull and damages that frontal lobe and that front part of the brain. And that's where these are housed, these decisions are housed to be safe. And so this individual may need some extra precautions and maybe actively working on being aware of those surroundings and other strategies to help that person be safe and enable them to continue participating. Because memory and attention can be affected, we oftentimes will rely on things like a checklist for memory. And that's, again, a lot of this stuff we can do from our phones, which almost everyone has a smartphone in this room. So checklists to help remind us what we needed to do. It can help others as well if we needed to collaborate with others. And reminders if we need an alarm to remind us to take a break. So I use alarms on the phones also from 3 sections ago with those repetitive overuse injuries. I will ask people to take breaks and they'll say, well, I don't want to, I just got to get this done. No, you need to take the break, because if you don't, this is what's going to happen, right? So you try to fit it within their routine, and you really have to know what their routine is. So the alarm reminders can facilitate that. And they're really easy to use, gaining attention as well. Okay, and so that was it. I just needed to cover a little bit of the brain injury portion. And so do you have any thoughts or questions related to non-progressive medical conditions that I talked about today? Nothing? Thanks for hanging in there with me. That's great. So I'm going to pass it off to Kim now, and she will cover the progressive conditions and considerations.